Hello everyone. Today we will discuss about the iron metabolism. So at the end of the session, the student will be able to discuss the iron metabolism, discuss the etiopathogenesis of iron deficiency anemia, and discuss the clinical features of iron deficiency. So first of all, what is anemia? Anemia is insufficient RBC mass to adequately deliver oxygen to peripheral tissues. Anemia is usually associated with decreased level of hemoglobin and or a decreased packed cell volume, it also called hematocrit, or a decreased red cell count. Definition of anemia: HB level of a patient which is below the normal range of that age and sex. For adult, WHO criteria to define anemia as hemoglobin level lower than 12 gram per dl in women and 13 gram per dl in men. But the reference value for red cells, hemoglobin or hematocrit may differ according to age and sex, race and altitude, socio-economic changes and study references, etc. Before making a diagnosis of anemia, one must consider age, sex, geographical locations in presence or absence of lung diseases. Now, iron metabolism. Total amount of body iron is approx 3 to 5 gram that contain heme compound, enzyme and non-heme proteins. Heme compound contain hemoglobin, myoglobin and cytochromes. Enzyme contains peroxidases, catalases, ribonucleotide reductase. And non-heme protein that approx 1 gram include a large number of sulfur iron binding compounds, the iron transport protein, transferrin and lactoferrin. Iron storage protein, that is ferritin for short-term storage and hemosiderin for long-term storage. A small loss of iron each day in urine, feces, skin and nails, and in menstruating females as blood approx 1 to 2 milligram daily. Iron absorbed in our body is approx in male approx 1 gram per day, in females 1.5 milligram per day. There is an increased need for iron during pregnancy, childhood and adolescence. Now iron absorptions, how the iron absorb in our body. Maximum iron absorption occur in the duodenum and upper jejunum. An increased motility of nutrients through GI tract or a decreased absorptive surface area in the GI tract may result in decreased iron absorption. The amount of iron absorbed depends upon the amount and type of iron ingested. Non-heme iron, which is in the ferric form in vegetable and whole grains, is not easily absorbed, while the heme iron, which is in the ferrous form and present in red meat, is more readily absorbed. The presence or absence of other food may interfere with the uptake of iron. The GI acidity in GI acidity and acidic conditions favor uptake of iron. Now, state of iron is stored in the body. Less is absorbed if iron storage is high. Activity of bone marrow: more iron is absorbed when erythropoietic activity is increased. And state of the intestinal mucosa: and in a state of severe iron deficiency, the body can increase the amount of iron absorption up to 30% of the dietary iron. Normally only 10% is absorbed to compensate for the iron depletion. Iron transport and storage: iron is transported from the duodenum into mucosal cells in the ferrous state where it is converted to the ferric state. It may combines with apoferritin to form ferritin or cross into the plasma. Into the plasma, two atoms bind to the iron transport protein and transferrin. The total iron binding capacity of the serum TI that called the TIBC is a functional measurement of the amount of transferrin. Normally, the transferrin in the serum is about 30% saturated with iron. The majority of the transferrin bound iron is delivered to the bone marrow where it binds to the specific transferrin receptors on the developing RBCs, normoblast, the release the iron in the ferrous state. This is the photomicrograph which is showing the absorption and transport of iron. The iron is absorbed, iron transport to the mucosal cells in the form of ferrous state where is converted to the ferric state. In ferric state, the ferric state bind with the apoferritin and transferritin. Then the ferric state transferred to plasma. In plasma, that binds to the transport proteins and transferrin. Now, etiologic factor in iron deficiency anemia. If there is negative iron balance, that is in decreased iron intake, inadequate diet, impaired absorptions, achlorhydria, gastric surgery, celiac diseases, duodenal bypass, drug that increases gastric pH like in tannins, phytates, bran, competing metals, increased iron loss, gastrointestinal bleeding, hookworm, schistosomiasis, trichuriasis, hemorrhoids, peptic ulcer, gastritis, hiatal hernia, and diverticulosis. Etiologic factors, again the neoplasm, inflammatory bowel diseases, arteriovenous malformation, varices, Michel's diverticulum, milk-induced enteropathy, salicylates use, excessive menstrual flow, gynecologic neoplasm, bladder neoplasm, and epistaxis. Inadequate presentations to erythroid precursors, atransferinemia, anti-transferrin receptors antibodies, abnormal iron balance, aceruloplasminemia, autosomal dominant hemochromatosis due to mutation in ferroprotein. Now, pathogenesis, whatever its basis, iron deficiency produce a hypochromic microcytic anemia at the outset of chronic blood loss or other state of negative iron balance. Reserves in the form of ferritin and hemosiderin may be adequate to maintain normal hemoglobin and hematocrit level as well as normal serum iron and transferrin saturations. If there is progressive depletion of these reserves, first lower serum iron and transferrin saturation level without producing anemia. In this early stage, there is increased erythroid activity in the bone marrow. Anemia appears only when iron stores are completely depleted and is accompanied by lower than normal serum iron, ferritin, and transferrin saturation level. HB synthesis is impaired, generalized defect in cellular proliferations, survival of erythroid precursor and erythrocytes is reduced, particularly when the anemia is severe. Now, stages of iron deficiency. Stage 1 is iron depletion. Stage 2 is iron deficient erythropoiesis. Stage 3 is iron deficiency anemia. Now, clinical features of iron deficiency anemia. First is general symptoms of anemia. Then fatigue may be disproportional to the degree of the anemia due to deficiency of tissue enzyme which is also need iron. Then we look for paleness. Look at mucous membrane of the mouth, pharynx, conjunctiva, lips, nail bed, palms. Creases of the palms lowers their pink color when the hemoglobin is less than 7 gram per dl. Chlorosis, glossitis, angular stomatitis, gastric entro, gastric atrophy, ozena, anosmia, nail changes like nail become brittle and fragility increases, koilonychia and spooning of nails, hair loss, and one is the Peterson-Kelly Plummer-Wilson syndrome, in that esophageal valve leading to dysphagia, pica, appetite for bizarre food substances like geophagy for earth and clay, pagophagia, ice, amylophagia, starch, developmental problems, splenomegaly, and Tannak Prasad syndrome, in that there is growth retardation, hypogonadism, hepatosplenomegaly, zinc and iron deficiency, and geophagia. And one is immune deficiency. So this is about the metabolism, etiopathogenesis, and clinical features of the iron deficiency anemia. Further reading suggestions: read Iron Metabolism, Etiopathogenesis from Robbins and Cochrane, Pathologic Basis of Diseases, and Dacey and Lace Practical Hematology, Clinical Features from Harrison Textbooks of Internal Medicines. And after this class, we will have again 10 MCQs to assess your learning whether you are actively participating or not. So further reading is suggested. Thank you so much.